Welcome, everybody. Thank you for joining us today. Welcome to the GE HealthCare Lunch Symposium at ISS this year. I'm Maggie Fung. I'm the Director of Musculoskeletal MR Imaging for GE HealthCare globally. Today, we'll take you through a journey of how we're developing new MR applications to connect the orthopedic care pathway. It's our pleasure to have two distinguished MSK radiologists today as our speaker. Our first speaker is Dr. Guggenberger, who is the head of MSK imaging in the University Hospital of Zurich. His research expertise is in UT imaging, fast imaging, AI, and also neurography. Today, he will take us through how he's using Zero-TE and also our new robust deep learning propeller technology for motion robust imaging. Our second speaker is Dr. Darryl Sneag from the Hospital of Skeletal Surgery. He's the Director of MR Neurography and MRI research there. He's one of the thought leaders in MR neurography, and today he's going to walk us through an advanced suite of neurography techniques and also visualization strategies, and how it improves diagnostic precision and surgical planning. So first, let me take you through our latest suite of technologies that helps in diagnosis, planning, surveillance, and post-op in MSK routines. So the many years, I've been in MR for 20 years, the many years that I work in the field, I learned one thing. If you ask an MSK radiologist, how much resolution is enough? What would they say? Higher. So now we can do higher. Look at this exquisite image with our deep learning reconstruction. The left is before, the right is after. This is achieving 200 microns or less than 200 microns in plane resolution with 1.2 millimeter thickness in a 6 centimeter field of view. You can see the increase in both SNR and sharpness using these deep learning reconstruction technologies. We call these deep learning reconstruction technologies AirRecon-DL. It helps improve signal and noise and sharpness. Since its launch in 2021, we have over 2,000 global installations, over 26 peer-reviewed journal articles, some of you coming from this community, and over 10 million patients scanned already to date. So it's really all inside the clinical routine already. It's raising the bar of clinical excellence across a broad range of applications. We start with having it compatible with 2D, and then now we make it compatible with 3D, propeller, flex, and also quantitative imaging. Here's an example. An AirRecon-DL with propeller enables motion robust shoulder imaging in under 10 minutes. Dr. Guggenberger will also show more images later on. It's also compatible with 2D flex imaging for fat water separation. Applying this technology to 3D is a game changer. For example, in this case, the sagittal T2 cube, which is isotropic, can be done in 2 minutes and can be reformatted into axial and coronal planes. In this acquisition, they also couple it with the fast sagittal T1 and sagittal stir technique so that the total scan time was reduced by 50% in this site in Boston. So they have been getting a lot of good feedback after the implementation of this technology. In addition, when you get more SNR, what does the MSK radiologist do? They push, like Darryl does. So these are some of the images, not from Darryl, because he's going to show a lot of images today, but these are from also other sites that is doing neurography sequence using these 3D techniques, such as cube stir for the brachial plexus and Manson nerve for the extremities. So you will see more of the gorgeous images from Darryl later. Another exciting development, which you have actually heard some from Dr. Eigengoose this morning on the talk, is Zero-TE bone imaging. We call it osteo, and this is really completing the missing piece of the puzzle in MSK imaging, where you can now see the cortical bone information. These techniques, because it's Zero-TE, it allows us to capture and differentiate very short T2 species, like cortical bone and calcification. then it allows you to generate CT-like images, but without any radiation. Think of the possibility when you have a pregnant patient or when you have pediatrics. In fact, our customers has been quite thrilled about this new capability. Every day, they're finding new uses of it in MSK, in oncology applications. This is just a few examples. On the planning end, surgical planning, right? People say a picture is worth 1,000 words. If you ask a surgeon, a 3D model is worth 1,000 images. We're happy to partner with Exo 3D, who is also in the booth today, to streamline the orthopedic 3D printing using MR-only images. Most of the orthopedic printing today is done on CT. Now having the capability to do it in MR, using Exo 3D's 3D cloud-based services, not only reduce radiation to the patient, but also open up the possibility of adding soft tissue information, such as this neurography case here. And you haven't done so, I encourage you to stop by the GE booth. We have this gorgeous 3D printing model and other bone imaging model that is printed directly from MR images. So I highly encourage you to come by. On surveillance, in terms of patient surveillance, especially for patients with OA or cartilage implantation, quantitative imaging may become more and more popular. But these techniques, such as T2 mapping, they're traditionally 6-7 minutes or maybe even longer. But now, thanks to the compatibility with Air Recon DL that I mentioned earlier, we can now accelerate higher and make it faster. For example, in this case here from Clínica Central in Spain, we accelerate up to a factor of 3. So it goes to 3 minutes instead of the 6-7 minutes. So this is showing a cartilage implant, a chondrocyte implantation. After 14 months, you see progressive organization of the repaired tissue. Lastly, for post-op, market research from Frost & Sullivan has shown us that the orthopedic device market is continuing to grow, which means that more and more of your patients coming in will have implant on board. The hypermaverick sequence is to address this and to image around the bone, around the metal implant. In particular, our latest version has patient-specific calibration, which allows you to tune the acquisition based on the type of implants this patient has. So for example, if we use a traditional maverick sequence on the left, it's 5.5 minutes. But if we tailor it to the patient, for this implant is made of a material that doesn't have a lot of off resonance, so we can reduce the number of bins that we require. So it goes from 5.5 minutes to 2.5 minutes, reducing the scan time. In addition, you can also reinvest the time and run it in an isotropic mode, as in the middle here. So you can see originally you have 4 millimeter thick, now you're at 1.3 isotropic, where you can then now start to reformat it in all 3 planes so that you don't have to acquire 3 separate long maverick sequences. So after this quick overview, I would like to hand it over to our first speaker, Dr. Guggenberger, to see how he's bringing all these from research to clinical use. Thank you.
Okay, well, thank you, Maggie, for the nice introduction, and hello, everybody, to this symposium. I'm happy to be here and to give a talk on the new kids on the block, Zero-T and motion-robust deep learning propeller sequences for MSK-MR imaging. So as a disclosure, I'm part of an ultrasound startup, which I guess does not have much to do with the talk I'm going to give today. And of course, I got some intellectual and research support from GE HealthCare. So what I'm going to talk about, we're going to briefly summarize what is zero echo time imaging about, how does it work, what is propeller imaging, it's already been out there for a while, and what could deep learning image reconstruction add, what possible value could it add to those sequences. So starting out with Zero-T and actually UTE sequences, they are based on MR imaging using really short echo times, and we're talking about 0.05 milliseconds or almost 0 milliseconds. The reason for this is that we can measure signal, MR signal, in tissues that would otherwise already have lost their signal on traditional MR sequences like bone, tendons, and ligaments. And of course, as any MR examination, we do not use ionizing radiation in order to depict those tissues. So if you have a look at this diagram, you can see that signal intensity of an MR signal decays over time. That's evident, we know this. But the T2 decay actually differs between different tissues. For example, muscle and fat, they keep a higher signal up to a longer time period as when compared to bone, meniscus, and scar tissue, which lose their T2 signal pretty fast. So if we could reduce the echo time towards 0, we would end up with a far higher signal of tissues that would otherwise already have lost a signal on traditional MR sequences. And where should we aim at? So we know that the T2 star decay of cortical bone is about 300 to 400 microseconds. There's different approaches to depict bone, actually, and probably some of you were using or are still using black bone MR sequences based on low flip angle, spoiled gradient echo images. I think they're doing fine. I like the bone contrast that we get there, but it's actually based just on the signal void that we get. And we cannot nicely differentiate. Do I have a pointer, by the way? Ah, well, I can use a mouse. I think it's working. Well, anyway. We cannot differentiate bone from adjacent tendons that nicely. However, if we go to the UT and 0T echo sequences, you can see that the differentiation of the cortical bone as compared to the surrounding tendons gets much more precise, and it's really only the bone tissue that's being left as a signal void. There's other sequences that may use additional long T2 suppression with an inversion recovery. I've never used those, and I will not go into those sequences as well. So we're really going to talk about UT and 0T imaging here. How do they work? Well, they're actually pretty fast, as they allow us to gain data, to fill up the case-based data pretty fast through a 3D radial trajectory. And the reason for this is that we pre-ramp our gradients before we send in the radiation frequency pulse. And this allows us to acquire the signal directly after we send in the radio frequency pulse, while the gradients have already been ramped up. So it's really a fast 3D acquisition with almost no echo time spacing in between the radio frequency pulse and the signal acquisition. So this is a study that a colleague of mine, Tim Finkenstedt, did when he was in his fellowship in California. You see this is a knee, it's a lateral compartment. You see the meniscus on a traditional PD-weighted sequence. And if you then go down with your echo time, you see that the meniscus somehow still gets some bright spots. And if you even get further down, you see that the meniscus actually brightens up. You have signal out of that meniscus due to that very low echo time, but you're still being left with some dark spots in that meniscus. And he excised those meniscus, and he also did micro CT. So those spots really corresponded well to some microcalcifications in the meniscus, which we could, or he could, detect with these ultra echo time sequences, ultra short echo time sequences. Traditional T1 weighted sequences, you know, we use them every day for imaging, or maybe not so much anymore if you do Dixon imaging with fat images. But usually we run across problems if we want to identify any problem in that interarticular portion. He also did a study where he, on cadavers, dissected that intra-articular portion with a saw, and he put them through a CT scanner. You can, of course, nicely see the defect there. While if you do UTE MR imaging, you can also pick up that bony defect pretty nicely. And if you do inversion of the gray signal, like a pseudo-CT, you get a very nice image of that bone defect, and you can actually do this in vivo too. So we looked at sacroiliac joints, in patients to see how the 0T was doing as compared to the traditional black bone sequence that we were using so far. You can see on the left-hand side, it's the 0T images. In the middle, it's the black bone. And on the right, you can see the reference CT images, and especially for subchondral sclerosis, for osteophytes, syndesmophytes in that region, also small erosions in those few cases of inflammatory diseases that we included in this study, you can pick that up pretty nicely on a 1.5 Tesla system. This, I have to say as a disclosure, almost all my images that I present are from a 1.5 Tesla system. We do not have access to a 3 Tesla system so far, but I'm still surprised and impressed of the image quality that we get out of our 1.5 Tesla system. So what does the osteo sequence provide from GE? It's based on a 0-TE image that's being put through a bias correction so that we get a more homogeneous distribution of the gray values of the image appearance. And then it also undergoes sort of intensity inversion to really come up with a CT-like image appearance that we are used to when looking at CT images. And this algorithm usually works pretty well, but you have to be aware that sometimes we get artifacts. For example, sometimes you may get aerated regions in your scan volume that are being depicted as if it was bone, but usually it's not that big of a problem. Like in this case, I've never seen a bone like this actually. Another example here of the forefoot. This was actually a patient with gout. You can see that there is some soft tissue mass at the medial aspect of the metatarsophalangeal joint. You cannot nicely pick up what's really going on in the bone, while if you look at the osteo sequence, you can see that there is a small bone erosion, and you can also spot those faint mineralizations within the tophus on the right side, something that you would, of course, not be able to see on standard MR sequences. Then the question is, okay, we do have 0-TE echo, 0 echo time images to depict bone, but is there a potential value of additional deep learning imaging reconstructions? What could they add to our daily routine? And this is a case of a patient who had pain in his right shoulder. You see some edema in the subscapular tendon. You also see some edema in the subdeltoid bursa, probably. But we were not really sure what was going on there. And these are pretty bad images, as the patient was not really positioned well in the scanner, and they didn't even put a dedicated shoulder coil on it. But already on those images, you would see that there was some mineralization, some calcifications going on in the tendons. If you then add the deep learning reconstruction algorithm, I think it's pretty evident that there are some calcifications in those tendons present, and this was actually due to a tendinosis, a calcific tendinosis in that patient. That's another case of a knee joint. You can see on the left-hand side the raw standard 0-TE images, osteo images, while if you add the DL recon, you get a much nicer images of those intra or periarticular calcifications in this patient with severe osteoarthritis. Another knee joint, you see on standard proton density fat-weighted images. He had some medial located knee pain. We were not sure what was really going on there. There might probably be a little bit of surrounding edema at the femoral insertion of the medial collateral ligament, while on the 0-TE, we could nicely spot a small flake there, especially on the DL reconstructed images. There was no doubt that this was an old avulsion of the medial, bony avulsion of the medial collateral ligament with sort of a Stieda Pellegrini sign and syndrome that you can develop there. Another knee case, you see a severe osteoarthritis of the medial compartment, and there was some debris in that ganglion on the medial side of the knee. We were not sure what was it. Was it just proteinaceous material? Was it probably old hemosiderin products? While if you have a look at the corresponding 0-TE images on the left, normal on the right with DL reconstruction, you can nicely see these cartilaginous calcifications and mineralizations in there, and this was actually a small spot of synovial chondromatosis. So 0-TE with DL seems to be useful, but maybe we can do more with this 0-TE, and that's actually an interesting study that I'm doing at the moment. We want to produce pseudo-CT images out of those 0-TE images that not only look like qualitatively like a CT image, but that also allow us to measure quantitatively the CT attenuation values in those images. So we took our CT images of the pelvis, we put them through an artificial convolutional neural network. We trained it with the reference CT images in order to come up with those pseudo CT images that pretty nicely look like the original, like the reference CT images. But if you, in addition to that, measure Hounsfield attenuations of cortical bone, spongiotic bone, or muscle and fat, you see that they're doing pretty nicely as compared to the reference standard. However, there are some areas where the algorithm is not doing that precise yet, like on the superior iliac crest on the left-hand side. But nevertheless, I think that's really an interesting development we're seeing there based on zero-T echo images with deep learning. We can produce CT images that do not only look like them, but that are also quantitatively useful, for example, for radiation planning. So we've already seen this. Osteo seems to be really an interesting sequence as a one-stop shop orthopedic imaging tool. We can do fast imaging. We have a CT-like contrast. We can co-register it with classic morphologic MR images, and we can do it quite motion insensitive and also use the information for volume rendering. We can use those scans for measurements in the bone, for example, femoroacetabular impingements. We can give exact and precise measurements. We see those calcifications, as I've shown you, in the SI joints, but we can also see them in the cervical spine. We can detect fractures, and it is useful as a raw material in order to generate pseudo-CTs that offer CT-like contrasts, not only qualitatively but quantitatively. So moving on to propeller, it's actually already been out there for a few years, and it's a technique to quite fast and quickly sample your case space data by rotating lines around the center of the case space so that you get sort of oversampling of the central case space while the periphery stays only with sparse data in case space. And why is that useful? Because in the center of the case space, we usually have the contrast of an image and maybe some very coarse anatomy located, while the more finer details are located in the periphery of case space. But we may not really need them, as has already been shown back in 2011 by a colleague of mine. These propeller sequences are fast and pretty useful, especially in patients with motion artifacts. As a side note, they also noted some more accentuated artifacts when using those propeller sequences. So propeller is an interesting technique to speeden up your image acquisition, and that's actually always something that we want to do when we are confronted with that fundamental trade-off in MR imaging. You know, we want to optimize our scan time, we want to optimize our image resolution, we want to optimize our signal to noise ratio, but it always comes at the cost of the other. So there's actually no solution that's really perfect for all of them, and there have been different techniques to tackle this in recent years, like higher magnetic field strengths, higher gradient power, higher and more element coils, parallel imaging, imaging filters, and fancy ways of sampling your case-based data like compressed sensing. So coming back to propeller as a way of efficiently extracting or filling up your case-based data, what if you took that sparse data and put it through an artificial neural network to then come up with deep learned imaging reconstruction so that you can not only acquire the images pretty fast using propeller technique, but also get rid of those that image noise and of the sparse spatial resolution. So the ReckonDL with propeller from GE offers that. You can choose manually how much of signal gain you want to have, low, medium, or high, of course at a certain trade-off of imaging time that you may need for this. But it's really straightforward, and it improves sharpness and resolution of the images that you acquire. This is an example that Maggie gave me from their phantom testing. You can see on the left side the conventional propeller sequence, while on the right, using propeller with DL, you get sharper images. You're getting rid of those ring artifacts, and the loss of detail is really not there anymore. And we've seen this in our studies as well, again on 1.5 Tesla, using propeller 2D sequences in addition to AirRecon deep learning reconstructed imaging. You can see on the left-hand side a coronal PD fat set images of the right shoulder. You see that there is something, some edema, some effusion probably in the subacromial subdeltoid bursa, but this was by far much more precisely depicted on those DL images. Again, a coronal example, you see the labral defect here ventrally, quite blurry, but if we look at the recon DL images, there's no doubt about that there is really some defect there, and this, of course, causes the problems of the patient. While at the same time, not only that we gain image resolution and image and spatial and reduce image noise, at the same time we substantially reduced our scan time. You can see on the left side, there's the standard sequence is pretty long, but as I said, it's 1.5 Tesla, and we could almost halve the scan time as a consequence of this propeller DL sequence. Another study we did in the knee joint using the same setup, more or less. Again, here you can see on the conventional MR images that there's already nice depiction of the retropatellar cartilage, while when using this AirRecon DL with propeller, you see those fine cartilage fibrillations, things that you might probably not see on the standard images. And also meniscal pathologies we can pick up really nicely. You see this tear in the posterior horn of the medial meniscus. It's already there on the standard image, but it's far more nicely depicted if we employ Recon DL images. We also did quantitative measurements, and this sort of confirms what we've seen qualitatively. The signal-to-noise ratio in different tissues, bone, fat, and muscle, is definitely high on these DL images as compared to standard. And after all, imaging takes almost half the time that it would take with a standard propeller approach. So having said all this, we also did a study on MR neurography. It's not only Darryl that can do it, but he probably does it best. We did it on a 3D cube stir sequence, also employing Recon DL, and we could show that this really adds also on 3D imaging to an increase in image quality. It's actually a fellow of mine who won the prize, the poster prize at this conference, and I think this is just a perfect slide as a bridge to hand over to the next speaker. So summarizing it up, I've tried to show you briefly what Zero TE is about, how does it work, why is it interesting, how is propeller working, why is it interesting, and above all, how could deep learning image reconstruction techniques add to both of these techniques, not only on 3 Tesla, but also on 1.5 Tesla. Thank you for your attention.
Thank you so much, Dr. Guggenberger, for this excellent talk. So our next one is with Dr. Sneag from Hospital of Cecil Surgery, talking about advanced MR neurography suite for improving diagnostic precision and surgical guidance. Darryl.
Thanks, Maggie. I'd like to thank Maggie, DJ Kwan from GE for inviting me to speak today, and really for the event organizers for doing such a good job putting this together, particularly Ken Lee. I'd also like to acknowledge my colleague in crime, if you will. Dr. Ek-Soon Tan is an MR physicist. We really work collaboratively together at the Hospital for Special Surgery to try to really keep pushing spatial resolution, as Maggie said. So thanks, Maggie, for saying my long title, my talk. So I'd like to just introduce MR neurography by describing some of the motivations for performing it. Well, in my mind, it's an important, in other people's mind too, it's an important adjunct to electrodiagnostic testing, which includes both nerve conduction studies and EMG or electromyography. It's helpful for nerve injury localization, especially when multifocal or fascicular in nature, as I mentioned in my talk earlier today. And it's been shown to influence surgical planning and outcomes, as shown in this paper by Dr. Chabra, sitting right here. And lastly, it provides a global assessment of not only the nerves and the muscles, not only the nerves, but also the muscles for evaluating denervation. I'd like to just share with you my kind of clinical experience. I formally started documenting how many cases we were doing in terms of nerve studies since 2016. And we see that there's a linear increase, or almost linear increase to today. We do about 130 nerve cases a month. And I think the increase in volume is attributed to improving image quality enabled by improvements of both software and hardware. And we have a website so patients can learn more about MR neurography. So what's the challenge in MR neurography? As Dr. Tam, my colleague, asked me each day, why did you choose the hardest kind of piece of anatomy to go after? Because they're very small. I find it interesting. It's a challenge. You want to acquire adequate spatial resolution, but also has to be within a clinically reasonable scan time. So the standard approach is to use high performance gradients, particularly at 3 Tesla, and high element surface coils. And so this is an example of a patient imaged in April 2013. They were followed up about 7 years later for surveillance of the large peripheral nerve sheath tumor. And note that by just using a combination of 2 flexible 16-channel coils compared to a more conventional setup of 8-channel cardiac coil, you can get markedly improved SNR. But we want to do better. And we want to particularly evaluate nerves cross-sectionally or orthogonally to evaluate their fascicular architecture. So parallel imaging techniques can be helpful. They typically incur SNR penalties due to undersampling and noise amplification. More recently, AI-based imaging reconstructions have been shown to be attractive because they could decrease scan times and at the same time improve spatial resolution for MR neurography. So what do we use? Well, I try to get all my patients imaged at 3 Tesla for inherent increased SNR, use phase array, closely confirming surface coils. In terms of software, I rely on both combination of 2-dimensional, heavily T2-weighted, fat-suppressed sequences, typically Dixon technique, because in my mind, that offers the best combination of SNR and robustness to fat suppression. For longitudinal imaging, so this is lower in-plane resolution, but much higher through plane on the order of 1 millimeter. I use fast-spin echo 3D image, so a cube stir sequence here. I sometimes combine it with a combination of intravenous gadolinium, where I can simultaneously suppress both the blood vessels that might otherwise obscure small nerves, as well as the fat. And then more recently, we've used Mensa nerve, and I'll get into some detail about Mensa nerve in a little bit. So just to highlight kind of the coil setups, and one of the most challenging regions of the body in my mind is imaging the brachial plexus, because you're dealing with a concave region where the B0 is very inhomogeneous. So you want to really get coils right into that area. So here are different options. On the top, you can use 2 flexible coils. Here are 2 air MP coils. And lastly, you can use an HNU with a combination of the air MP or flex and a posterior array. I'd like to highlight the use of the 2 air MP coils because of the ease of setup for the patient. So here is a volunteer being set up. They're just lying on one of the multi-purpose coils, the large air MP coil. The technologist is able to easily position the medium air MP coil. We found in our experience that patients are very comfortable with these coils. They're not heavy. And the technologist feels comfortable as well because they know how to set up the patient over and over again without too much of a struggle. So just to shift gears slightly, when we talk about image quality and efficiency, there's usually a balance or a compromise, if you will, between spatial resolution, contrast resolution, the time of the acquisition, as you may know. AI techniques, such as Air Recon DL, however, is able to kind of avert this terrible triangle, if you will, or pyramid, by achieving high image quality and efficiency without compromising spatial resolution or contrast. So Air Recon DL is an AI-enhanced image reconstruction pipeline. It operates on case space data to produce high-quality image, and it's being trained using a curated database of more than 10,000 high-quality images. Here's an example of imaging of the sciatic nerve at the level of the ischial tuberosity. This is the same acquisition. and it's reconstructed two different ways, one with a conventional reconstruction on the left, and on the right here with the Air Recon DL reconstruction. And note the improved conspicuity of the fascicular architecture. In fact, we published a study in magnetic resonance imaging evaluating 60 peripheral nerves, and we showed that the two very important characteristics of nerve evaluation, that is the fascicular architecture and the outer epineurium, are improved when evaluating the DL recon versus a standard reconstruction. So that's for 2D imaging, which, as I mentioned, is very important to provide high-resolution orthogonal imaging. But 3D imaging, in my mind, is also critical. Again, because you're typically able to acquire much thinner slices or slabs, if you will. Now, obtaining 3D imaging, though, is challenging, particularly if you want to create an isotropic acquisition where you're pushing not only the through plane, but also the in-plane resolution. Why is isotropic acquisition imaging appealing? Well, you can take the 3D data set, as you know, create multiplanar reformations. And typically, if you can acquire a faster single acquisition than multiple 2D scans. However, the problem with 3D imaging, it typically incurs increased blurring related to the longer echo train lengths that you're using, and also noise as well. However, with the Air Recon DL, we've not only applied it to 2D imaging, but we can now apply it to 3D imaging. So this is an example of a patient which we've taken, we scan them with the same spatial resolution on the left as compared to the right. So this is a standard reconstruction, 3D cube SIR. The scan time is about 7.5 minutes, where here we're able to acquire a faster cube SIR sequence in just 4 minutes. And using the Air Recon DL algorithm, here we're able to identify focal constrictions, the C5 nerve root, and the suprascapular and axillary nerves in this patient with Parsons-Turner syndrome. And so we have a paper in Press where we evaluated 30 patients using a standard and a fast acquisition. We showed a reduction of scan time, a mean of 33%. We found superior SNR, but similar nerve conspicuity with a high inter-rater agreement. And this was enabled by the Air Recon DL. We also do a double oblique acquisition. So we're really just focusing on the nerve segments to reduce the number of slabs acquired, and an inner volume excitation to avoid wrapping. So here's just an example, the standard non-DL acquisition compared to the fast DL acquisition. You note that the fast DL acquisition, they're similar to arguably improved image quality, but in markedly reduced scan time. And you can argue the scan time, yes, it's helpful for the throughput of the magnet, but particularly with 3D imaging, with longer scan times, you're introducing potentially a lot more motion artifact. Just one word on imaging around metal. I found using Hypermaverick Cube STIR very helpful. You may think that you always want to put metal at the lower field strengths to reduce the susceptibility effect. But I would argue with nerve imaging, you really want to make use of a higher SNR at 3T. And we can image, and I do image almost all nerve cases, even if there's metallic hardware at 3T. And Dixon, as I mentioned, is pretty robust, but if the nerve is just adjacent to the arthroplasty in this case, it will be obscured. However, a hypomaveric STIR sequence can reduce the susceptibility effect, and we can nicely clear, if you will, the terminal branches of the brachial plexus. Okay, so I'd like to spend a few moments on talking about Mensa nerve. I find this really exciting, and it's really been a workhorse sequence for me in the last year and a half or so, introduced into most of my protocols. Mensa has been around as a product, a 3D multi-echo and steady-state acquisition, and it's a single acquisition. It provides high-resolution 3D MRN. You get two echoes, an S plus and S minus echo, and the S minus echo is really the one that we're after. This is one that, although the SNR is lower, provides greater T2 weighting and excellent, at the same time, excellent fat suppression, but also improved vascular suppression. So it's the S minus echo, which we can extract. It, in my experience, has improved sharpness compared to FSE imaging. I'll just show you an example. On the left here is a T2 weighted flex, that's 2-point Dixon fast-spin echo sequence. On the right is a Mensa nerve, second echo. Here we can nicely see the median ulnar and posterior interosseous nerves, and it's particularly helpful for evaluating the posterior interosseous nerve. In this case, there's a mass arising from the posterior interosseous nerve because it has the added benefit of vascular suppression. So you can nicely just highlight all the peripheral nerves and ensure that you're looking at nerves and not blood vessels. So as you know, as the pin goes through the supinator tunnel, accompanied often by a cluster of vessels, the leash of Henry, it can sometimes be challenging to delineate the posterior interosseous nerve from the adjacent vessels. We typically apply it to the lumbosacral plexus and extremities because the one caveat with Mensa, it can be susceptible to motion artifacts, so particularly around the lungs, you can get a lot of artifact. And like shown with ZTE, propeller, you can apply 3D air recon DL also to the Mensa sequence. And this is just an example. Here's that S- without and with DL. And here on the zoomed in magnified insets, here look at the median nerve without DL and the median nerve with DL. Arguably, you can see the fascicular bundles of both the median and the ulnar nerve is much better on the DL reconstructed image. So we've extended it to evaluate the lumbosacral plexus. I must admittedly, I was a little wary at first because since this is a relatively motion-sensitive sequence, you do have abdominal wall motion and bowel motion, but I've been pleasantly surprised that it's really held up and being robust to imaging the lumbosacral plexus. So we typically acquire an acquisition of about 0.8 millimeter isotropic right now, and we incorporate air recon DL. Here's actually just an incidental peripheral nerve sheath tumor rising from the right femoral nerve. This is a patient actually who had an obturator neuropathy. We see enlargement of the left obturator nerve. We can acquire the sequence within about 5 or 6 minutes. And we are currently analyzing and writing up data where we evaluated 17 patients looking at terminal branches of the lumbosacral plexus. We showed improved nerve conspicuity for the distal segment of the femoral nerve, and also for evaluation of the smaller nerves, both proximal and distal segments for the obturator and lateral femoral cutaneous. And we showed improved interrater agreement from moderate to substantial using the DL reconstruction. So just some examples. So you can take, 3D imaging and create these multiplanar reformations. Very nice to show your referring physicians and patients. So here is, a patient with, we're delineating the femoral nerve, arguably with the air recon DL. You can nicely see the femoral nerve in greater detail, and the lateral femoral cutaneous nerve, not only as it's exiting the pelvis, but along its intrapelvic course as well. So why 3D MRI? Again, useful to appreciate the nerve course. And we've now applied this into the facial region as well. So here's a patient with an acute Bell's palsy, 35-year-old woman. We see a very bright and really enlarged facial nerve. I don't have the contralateral side for comparison here, but it was enlarged compared to the contralateral side. And then you can create the Mensa curved MPR showing the facial nerve entering the parotid gland. Similarly, you can evaluate the extraforaminal cervical nerve roots as well. And then you can keep going. As a musculoskeletal radiologist, I think I've told Maggie this as well. I really tried always to stay below C4, but it's just too interesting to not keep looking higher up. I know there's others in the room who like Dr. Chabra here, who routinely image these nerves, and I see why. So anyway, you can show the course of V3. The inferior alveolar nerve is a pretty easy nerve to visualize going through the mandible, but you can look at smaller nerves, facial nerve, as I showed you before. Here's the spinal accessory nerve coming from the jugular foramen. You can follow its entire course through the neck, and then as it's innervating the sternocleidomastoid and trapezius, and lastly, the vagus nerve here as well. So we take the Mensa nerve, and then following Roman's talk, we showed beautiful osteoimaging. We can create what's called fuse renderings. So this is a 70-year-old male following C-spine surgery. He had occipital neuralgia, severe left-sided occipital neuralgia. So here we acquired an osteo sequence of the skull base, upper cervical region. That's just the artifact from the instrumentation. And then here's the Mensa nerve DL, a curved MPR, showing the greater occipital nerve arising from the C2 DRG, the dorsal root ganglion. And here is marked enlargement of the left greater occipital nerve just before it's going to pierce the semispinalis. And then you can take the Mensa and do a colored rendering of it, as well as the osteo, and fuse them together. And I'm now more recently working with a plastic surgeon who does a lot of headache surgery, and I can illustrate to her, and hopefully she finds it useful, to show her exactly what's going on and where it is. This is a case report we published recently in Radiology showing a rib synostosis. Again, you have your cube stir up top. Here's hyperintensity region of the divisions, the synostotic rib. Then you render the ZTE, you render the cube stir, and you fuse them together. Admittedly, I have a lot of help from both scientists in my lab and also from Maggie, Fung here to create some of these volume illumination renderings, and again, to illustrate where the abnormality is. So right where the synostotic rib is, that's where it's impinging the brachial plexus, accounting for the signal hyperintensity in the region of the divisions. And since I'm actively studying Parsons-Turner syndrome, and occasionally in rare circumstances, surgeons will go on to operate on the patient if the patient has recovered, I can nicely show them the relationship of the nerve constrictions of the suprascapular and axillary nerves in this case in relationship to the bony landmarks. And here's just an example of that axillary nerve hourglass constriction provided by an intraoperative photograph. This is one of my last cases. This is a 10-year-old girl. She had pain and diminished sensation in the median nerve distribution following elbow dislocation and relocation. So here, obvious elbow dislocation, relocated, had median nerve symptoms. We acquired a Mensa sequence. And here we found, interestingly, the median nerve became entrapped in the apophyseal growth plate of the medial epicondylar apophysis. We acquired a ZTE sequence, ran it through the DL reconstructions for both Mensa and the ZTE, and then we're able to fuse the renderings together. And here, the feedback was that the surgeon felt very helpful to understand the relationship of the median nerve that became entrapped within the fracture site through the medial epicondylar apophysis. And here, just illustrating, again, the median nerve. Here's the humerus proper, if you will, and the medial epicondylar apophysis, and the median nerve entrapped in that site. I lied. One more case. So this is also just another way you can use these renderings to help with preoperative planning. Here's a 20-year-old woman, left upper extremity pain. Can clearly see on the radiograph an exostosis. She went for MRI. They wanted to understand the relationship of the exostosis to neurovascular structures. So here with the axial mensa, we can nicely see the exostosis. There we see the radial nerve. Then we did time of flight angiography. So this is non-contrast angiography, delineating again. Here's the exostosis, and here are the brachial veins. And then we can render both the time of flight angiography, the mensa, and the ZTE all together. As you see, the pattern trying to increase the number of fused renderings and exostosis. And then you could spin it around for fun. I think as a radiologist, I underappreciate the spatial relationships a bit because I'm not in the OR looking at a patient down the line. I have the ability to just, use axial cuts and really understand that spatial relationship in my mind. But I think the surgeons, for them, they're much, more used to looking at longitudinal images and rendering, and it's sometimes difficult for them to understand the relationships as easily. And lastly, 15-year-old male. This is, I really hate seeing these cases, as you might as well. It's usually young patients. They have a knee dislocation. Often it's a football injury. And unfortunately, this doesn't typically end well. This is a long segment enrollment continuity of the common peroneal nerve leading foot drop. Here, we were able to, again, fuse the, in this case, we actually able to fuse the Dixon with the ZTE to try to help the surgeon understand the length, or the segment length that was involved. These are occasionally grafted, but in this case, the length was too much, so they decided to go on with a transfer procedure. So take-home points, again, optimize hardware and software for improving diagnostic precision. You want to use flexible coils, and I found the air MP coils very helpful for obtaining adequate SNR while providing patient comfort. I found the Air Recon DL algorithms very helpful, again, for proving SNR. So I'm really trying to push the spatial resolution while maintaining adequate SNR. Mensa nerve I found very helpful, particularly in the extremities and the lumbosacral plexus, to obtain high resolution images that also provide adequate vascular suppression. You can help improve surgical guidance through integrating anatomical information, both the nerve and the bone relationship, and even blood vessels, if you will, through a combination of osteo and the Mensa nerve and fused 3D renderings. So thanks very much for your attention. Again, I'd like to thank many individuals listed here from both GE HealthCare and our MRI lab.
So thank you so much, everyone. Thanks, Darryl, for the excellent talk as well. And this concludes our session. So if you're interested to know more, we are at the booth for today and tomorrow. So feel free to drop by. Okay, thank you.